Thank you for your wonderful presentations. I have a question for Kevin. As a physician or a doctor, as far as I understand, do you really think the public health specialists had a power or a say in this, or do you think the clinicians were a little bit more talking and the public health was held back by the clinicians? Because that's what I think, in my perspective, infectious disease specialists and the clinicians took over the voice of the public health specialists. What do you think about that?
Thank you. I have two questions. The first one is for Aisuda. I love the way you finished the presentation. We're not prepared for the next pandemic. So thinking about like how to prepare for the next pandemic, I would like to know, how do you think would be the best way to embrace the difference in risk between what is a public health problem and what is an individual tragedy? And I'm asking this because I would like to know it from a social perspective, specifically how would you think that would be the best way to make people aware of these differences? In the context, for example, mothers will be completely against sending their kids to school. But so I would like to know more about your perspective. And my second question is for Colleen. I'm from Latin America, so I do understand like the context of the health system, but I was really surprised about. So you sent us before the conference the document. So something that got my attention was, I'm gonna read it. It's, in Nicaragua, public health care is free, so it should be no surprise that Nicaragua has dealt very successfully with the COVID pandemic. As an economist, what I understand is when a public service, when a service is free, it's usually can tend to be underprovided, especially if there is like a pandemic and everything is collapsed. You've been mentioning about like the policies that have been implemented not only like recently but over the years, because in order to build a strong health system, it takes years. It's not something that will happen from day another. So and also you mentioned about the transversality between other sectors like the infrastructure, energy. So I wonder if there is like any specific policy or something that has been going on in Nicaragua like years ago, because something must happen there, like in order to build this health system, and also that this goes hand by hand by roads, energy. So I wonder if there is, if there was any specific policy or something like that. Thank you.
Yeah, my question, or rather a comment, is for the presentation of Aisuda. You talked a lot about the correlation between COVID mortality and age, and I think it has to be pointed out that age is only a correlated factor, or mostly I think a correlated factor, because age is associated with comorbidity. And from all the data we have, we know that more than 98% of the COVID deaths are associated with comorbidity, at least one comorbidity, and 50% even have 3 or more comorbidities. So I think the underlying cause for COVID mortality is comorbidity and not even age. And of course, if you look at the figures, for example, in Austria, even the people above the age of 85 only have a mortality of 10% of COVID, which means that 90% of the 85-year-olds survive COVID very well, very well.
Yeah, that's a great question. I would say that I know Canada and the US the best, being a citizen of both places and having spent most of the pandemic. I spent about a year in France as well during 2020. And I would say no. I mean, on one, so if you, for example, there's been quite a number of studies looking at like the composition of advisory groups, right? And most of those show, the advisory groups, and these are like international studies, that most of the people in the advisory group were biomedical experts, predominantly clinicians, but there were public health people there. Now, in public health, you have like public health folks who are also clinicians, right? So they have an MPH, but they're also a doctor. And I think that those people tend to be seen in a more prestigious light in the public health community itself, right? Because you're a physician and you understand society, right, so to speak. So my guess is that there were certain types of people in public health who were valued more, who had more of that clinician background. Now, there were also a lot of clinicians that were very against non-pharmaceutical interventions because they were seeing pediatric emergency visits, or they were just thinking like, there's going to be this surge after we're done. What do we do with our cancer patients? What do we do with this, with that? So I don't think that fully explains. Maybe in some contexts it might. In Turkey, I don't know, right? I think that there was an issue around access to the media, that the media picked and chose its experts that it wanted to display. And so I've spoken to quite a number of, well-distinguished colleagues, et cetera, people that I know, and they said, well, I just wasn't invited to give my voice on anything. So I would say that probably determines the public debate more so than other issues. I think there's also in North America, there's a sort of unique cultural trend right now around what's been called safetism, right, from Jonathan Haidt's book, Coddling of the American Mind, which is where that safety, and this is part of the reason why when I go home, I'm going to see young people my age masking even outside the airport in Seattle. Safety is seen as the highest moral value, being safe, making sure everyone else is safe. And that also extends to safe opinions, right? And this is a trend that's going through the academic world in North America very strongly. And so I think that also helped to corral public opinion. And, there's other issues. Sorry, I'll stop there.
So how do we differentiate between public health crisis and individual tragedy, and how do we communicate that? First of all, honesty would go a long way. They aggregated data of 0 to 18-year-olds COVID deaths, and they said children, whereas we know that 0 to 1, 1 to 5, 5 to 11, and 11 to 18 was the real, that's how it was divided, and they were vastly different. When it fit to their purposes, they underestimated certain factors. They hid data. We could not, during the pandemic, I looked for point data, like individual level data, and we always got aggregated data from all the countries around the world. They had the data, they hid it for whatever purpose, because once you have the data, you have the information, you can actually interpret it. The thing is, if you keep telling people something, they will believe it about risk. If they can't, I'll just give one example and end it. Kidnapping of children is a very unusual thing. When it happens, kids are kidnapped by their family members, not by strangers. If you put a kid out on the street in the United States, you'll have to wait for 2 years for a stranger to come and kidnap the kid. Our perception is that our children are constantly at risk of strangers coming and kidnapping them. That's because of the media emphasis on single individual events, which are personal tragedies. But we should go by statistics on these issues. And talking about the single biggest public health issue, I think, was the nursing homes during the pandemic, especially the initial phase. And we could have talked much more about that instead of focusing on, and we never ever talked about the poor people. And I hated everyone in my class, like when I say class, like social class, economic class, so much, because it didn't matter if they were rightists or fascists or leftists or socialists. They were like, isn't lockdowns is so romantic. I'm making sourdough bread. I'm like, people are starving. Like, I wasn't against lockdowns, but after 3 or 4 weeks, I'm like, oh my God, like kids are being beaten. This is happening. How do you not see them? And we got the response with, my child is fine. And I just want to say, if your child is fine, statistically, we should start talking about statistics, but media is so central in this. What do they problematize? What do they talk about? I think that is honesty and talking about the real issues other than whatever they need to feel the need to emphasize.
The second question also you can take off on COVID and age.
It was more of a comment, but I'll leave it to Thomas maybe to address that. I agree. It's mostly comorbidity. But in the end, what matters is that old people, just from a public security, health perspective, and that's the thing, we got so much information, and that was the second part of my presentation. Everything was so much obfuscated, like and so much information that we couldn't see the things that were in plain sight. Old people die way more. Washing hands doesn't work with COVID. It helps with other things, but that's not really the most important thing in COVID. Cleaning surfaces doesn't matter a lot at all. Why are you wearing some, mask out in on the beach or street, like things that didn't make sense. We kept talking and discussing, and we knew it, and things that did make sense, and all the experts knew it. They just got lost in all this noise. And after a while, we just realized, or we thought that this was intentional. Like, if you want to give a message, give the message. Don't give 20 points where only 1 or 2 are important, and hide them among 18 other things. What was going on with that, communication strategy? Public health officers are not that stupid. I don't believe that.
Yeah, Colin?
I didn't understand, there might have been a mistake in the thing about what is the free and the quality. I mean, obviously, free is free, but there could be bad quality, good quality, but I think what we're talking about is basically quality and quality health services and free.
Put the health system of Nicaragua the way they are right now. You mentioned in the macroeconomic policies, the roads and everything. So as I've been saying, to build a specific health system, a strong health system, it takes years. So I was just wondering when this started. Yes.
It basically started a little bit in the 80s, but not much could happen because of the war and the poverty. In 2016 really is when they started, in 2006 rather, excuse me, is what 2006, 2007 is when they started doing the poverty plans, for example. And then just building up the systems little by little, evaluating after 3 years, doing a new plan. And and so you help to extend the health system, because it is a national regional health system. You go into the MINSA, and it's coordinated globally at the Managua level, but there's 18 regional offices and then subdivisions, et cetera, all the way down to the bottom, which is like a 3,000 people community. And you get onto their websites and you see exactly where all the health centers are, who are the brigadistas, what are their main problems, who are the people who have, it's very, very detailed as far as the population that
I think what is also this free services, generally a number of countries have tax-based, budget-financed, public health delivered care, public health services delivered. Most of it in Nicaragua you're mentioning is that.
Yeah,
so therefore it's free to the person. It's not free in that sense.
Oh,
It's
yeah, I mean, the person
paid
doesn't
with
pay,
your
but-
taxes on that.
but your taxes in the government budget and any other, international aid that comes in, et cetera.
The Costa Rica also has a similar system. It's much more based on social insurance, but it's works on that.
I had 2 questions for Kevin. The first one is more of a clarification. Could you just refer to the Swiss cheese model again? I think I lost the concept there. And then secondly, I was very pleased that you mentioned the concept of experimentation during this entire lockdown experience, which reminds me of different talks that I saw circulating also in the media about whether the so-called 1947 Nuremberg codes have been violated, which basically delimit the permissive medical experimentation on human subjects, and according to different scholars, they have been breached. Can you maybe also elaborate on that, what you saw in terms of this concept of experimentation? Thank you.
So my question is for everyone. Was there any discussion of the condition of people's lungs? Because this was a respiratory disease, and this was observed in India, that the cities, which we have massively polluted, metropolitan cities, lungs already had these black spots and so on, even for very young children living, for example, in New Delhi. And so there were public health officials and doctors who were talking about this, but then they kind of disappeared from the public media. So was this part of the discussion at all in terms of keeping people healthy, or what factors made it worse or better for people in different areas of the countries, various countries?
My questions to Kevin. Sort of just looking at some of your slides, I got the sense that a lot of the work that you reviewed was on literature from the north. I was just wondering how appropriate would your framework be for settings in the south, and whether you came across similar literature from the south that looked at sort of responses not from perhaps the lens of otherness, was sort of the global south given some literature that gives agency to the south in terms of how they responded to COVID, rather than looking at the Magufuli case is a good example, where you sort of had a caricature of the president's intervention that was not consistent with, perhaps, globalized narratives around how COVID was supposed to be responded to.
So, yeah, it's not really a question, but I have a few things to say. First, Kevin, I wonder if you have looked on the website of the ILO, International Labour Organization.
Yeah.
They don't have good data?
They do actually. I use
laws? Okay.
yeah. I use their data.
Yeah, they have very good data.
They do.
So I didn't mention in my talk earlier that the UN owned UN entities and also the community of NGOs withdrew their international staff from the field from countries where they were based and served the first year, under the pretext that their insurance was not covered for expatriation. And I think that also disrupted a lot of work, but and of course data was not good and so on, and it's absurd when you think that someone is serving the Pacific region in Fiji and now is working in Spain. So it happened all around the world, and I find that really stupid. So we had lots of data, but also because of that, and secondly, yes. So I think this is my second point. I really agree with that with your talk about dishonest information. I think that I used the website of Oxford very early to calculate risk. I think it was very good. Also had a feature on obesity, how much you weigh and so on, to try to calm some people around me down. But I think that even, when we knew that the risk was for elderly people, heavy and so on, we should have respected people's choice and the choice of their family. I know a tragic case when a man had to kidnap his mom from the nursing home in New York and then live with her in a caravan in the forest because it was illegal. I mean, how come our situation, our society, tolerate or push him into, committed something like that? It's just very sad. So I think that when we, if we do recover from this crisis, we should think that the doctor or the physician should have the duty to give us honest information, but the people who decide is us and the family, the person who takes care of the patient.
Well,
yeah.
That's a comment. So I think we can have Kevin and then maybe the others who are...
Yeah, and I'd also like to hear other people's opinion about experimentation and this kind of stuff. The Swiss cheese model was basically, if you look at it, it's all the different ways that you can help to stop the spread of COVID. So one of the holes in the Swiss cheese model is wearing a mask. Another one is staying home. Another one is getting vaccinated. And so you have about 15 of these things that you can do. And it was part of, we've struggled with this question of how do you define lockdown, right? Is it just stay-at-home orders? Is it stay-at-home orders, like what type, et cetera? I would say it's actually a mentality. It's a command and control, technocratic mentality, right? Where we need to maximize our efforts to control a respiratory virus. And we almost got into spacesuits, right? Like people wearing full-on spacesuits. I mean, I saw people almost in spacesuits in the airport during the time. So it's actually a mentality. Yes, it's a set of policies, and I've used this term COVIDization to try to describe that. And so in the question of experimentation, I mean, very early on, Neil Ferguson, has this very famous or well-known BBC quote in April, even March of 2020, saying look what Wuhan is doing. We could never really implement that here in Britain because we're a democratic state or whatnot. And so there was this recognition that, oh, no way, it's not going to happen. But it did. And, we had never been sort of confined to our homes before outside of a war situation. And in fact, even the evaluations of freedom restrictions. Like The Economist has a quote saying, COVID was the largest restriction of individual liberty since the Second World War, and outside of peacetime and possibly even wartime, right? Because even during wars, I think you could still move around. You might have other restrictions, but so I think there's a lot of elements of experimentation that took place. And finally, on the point about the literature that I reviewed, I would say more than half of it, or at least half, is from the Global South. So but certain issues you don't have data from the Global South, particularly around lifestyle data. So around like, screen use or sedentary behavior. And then you also have situations where a meta-analysis will have, 80 studies from the North and 20 studies from the Global South. And then even in those 20 studies, it's from like 5 countries, right? So you do have this patchwork, but I did, in the report itself, I do really try to bring up cases of literature from, Kenya or Nigeria or India or wherever. But there's just less data, right, from those countries. So I think there's an issue around trying to generalize, right, and trying to say, okay, for example, obesity increased by 2% in children during 2020, right? That's one meta-analysis found that. Well, okay, what does that mean? In some countries, maybe it went down. In other countries, it went up. But that's a generalizable statement. So there's limitations to making generalizations, in the world. But
do anybody want to take the question on the?
I have an easy answer. We did not discuss this in Turkey. Once you bring up the air quality, you don't want to bring that up as the government. And air quality, especially in urban areas, has been really terrible in Turkey. And in public health, the government does not want to discuss that. It's causing a lot of problems, obviously, in children. And it did not come up very often. I've never actually heard about it in the context of COVID policies.
So the respiratory chronic obstructive pulmonary disease as a comorbidity for this, mixed. You have some places which mention it, but many places do not include it in the thing. But that, as you may say, may be just the bias of the fact that many of these comorbidity definitions were from the North. So I don't know that. I'm just saying, if anybody knows, it's okay.
Could I just say something quickly on the issue of comorbidities, right? I would say that that's an area where public health failed abysmally. I mean, I remember a McDonald's advertisement saying "get vaccinated" on the cheeseburger, right? And there were some Nordic countries. I remember seeing advertisements saying "stay healthy," right? And it's like health policy became unhealthy. Stay home, stare at the screen, be scared. I mean, that's the opposite of having a healthy immune system. And I would say it was a pretty big deal to not have good health advice. It's almost like the conventional idea of being healthy has somehow become equated with being an anti-vaxxer and being a conspiracy theorist in this sort of hodgepodge cultural milieu. And so people are almost reluctant to say, oh yeah, you should be healthy and to exercise, right? This is from a U.S. perspective, so it might be very different.
Yeah, in Germany, for example, from day one, including Merkel, had said, go out, exercise, keep walking. Just don't socialize. Which is also, that's another thing. But there was a lot of emphasis on going out to the parks.
Even
and
England.
then I was thinking, people can't go out in Turkey even if you're allowed. There are no parks left. Sidewalks are not walkable. That was also a major problem, right?
Yeah. No, but this thing about this being allowed to go a walk and ask in contrast to a curfew, there seems to have been quite a north-south divide on that. Even if you see at Public Health England, you see at France, all of them had, specifically England had said that you can walk for 1 hour per day, alone or with a member of the family. So whatever looks, but over there that was particularly considered dangerous because at that 1 hour it may leak out and get into the environment. So this whole notion of it was there.
Sundar, we've got a couple of online questions from the chat. Can you guys, you can see this in front of you. So, yeah, there's one for Kevin. There's also question
let's
2.
Start with Pedrito.
Pedrito first, then we'll go to Kevin, and then Toby keeps waving at me as he's done all day. So I'll go to Toby, and then I'll go to Tom Riss, because Tom Riss has been very patient, and then we'll come back to you guys if that's okay. So we'll pass those 2 questions to you now.
Okay, so the question for me is, what was the main criteria for and sustainability used in selection of poor households for their assistance. Anyway, in Mozambique, we have what are called Secretary do Bairro, the secretary of the compound, the leader, the chief of the compound. So it's the chief or the leader, the secretary, who can say or can tell the government or those one helping people that this household is poor and he needs help. But what happens is that most of the time there's no justice. People are chosen according to political party membership or familiarity and so on. So those who really deserve to be helped, sometimes they are not helped. And those who doesn't deserve or don't deserve are those ones being helped. So there's a kind of either political influence or corruption. If you have got money, I can put you in the list in order to be helped. If you don't have, you're going to die. Unfortunately, pandemic brings poverty plus poverty. Those who are poor become more poor, and those who are rich become more poor. Thank you.
No, you're saying don't hold the mic when you speak.
Yeah, that was a great comment. This is a question from online. Okay, so what are the 3 top harms? My goodness. Okay, quickly, 3 top ones. Freedom. The redefinition of the state-citizen contract. What do we think is acceptable for the government to do? Lasting consequences to that, right? The public still supports what happened. If you look at public opinion polls, I have some questions about the validity of that, and I'd like to spend some time thinking about it because I think that it's a lot more complicated than we think. But it seems like a majority of our fellow citizens think that that was a bang-up job and we should have done more of it, right? So that's a problem going forward. Number 2, poverty, which I would relate to food insecurity, because the numbers are actually quite similar. If you look at, this is UN report stuff that I'm going to cite here. 400 million people fell below one of the 3 accepted poverty lines, okay? $2, $4, $7 a day. 100 million fell into dire poverty, which is the lower poverty line. So it's 400 million people who have less savings, less money in the bank, less money to make their livelihoods, right? About 300 million people fell into food insecurity, and about 60% of that was directly attributed to the COVID recession. Okay, so food insecurity was actually increasing before the pandemic. I'm getting back to sort of the challenges of attribution here. We're seeing a reversal of poverty, reduction trends over time, and we're seeing this widening class inequality that's taking place between essential and non-essential, or the laptop class and the non-laptop class. Interesting quick stat here: 17% of people were able to work from home during the height of the lockdown. 500 million people around the world. Those, I would say, lockdowns were a policy for the 17%, of which we're all part of, right? So that 17% is, they're the ones who run the show: media, creative industries, government, et cetera, et cetera. So, yeah, poverty, food security. The last one, 3rd, is the mental health impacts and the educational impacts on children. We know from social determinants of health research, like there are milestones of development, and if you disrupt those, the chances are people are out of school, right? I don't want to go to school. School's a bunch of whatever, BS. I don't trust the adults anymore. They made me wear masks in school all the time, and I had to take it off to eat and then put it back on and take it off to eat, So the impact on kids is also, I think, number 3. So,
thank you very much, everybody. Really interesting discussion in each of the papers. I just want to focus on the title of the panel, Policy Lessons for the Future, and the resurfing of local agency. So I wanted to ask the 3 of you speakers who spoke specifically about lower middle income countries to reflect on that. So Pedrito, local agency in Mozambique, was there a sense in which people in Mozambique quickly found ways around the policies, and is there something there that can be harnessed for the future? And I also have a very specific question for you. When we spoke for the Collateral Global podcast 1 year ago or more, at that point, it relates to what Janos was saying earlier about suspending vaccination programs. You said then that even then, so 2 years after COVID, the vaccination programs were still suspended in Mozambique. Has that changed in the last year? That would be my other question for you. Khedi, I want to ask about the Cape Verde agency. So, like, because the impression, is it easier in Portuguese? A minha impressão foi que durante a fala that the Cape Verdean state did not care about the informal settlements. There was not, like in some places we get the sense that there was a lot of restriction, but that it seemed like in the informal settlements in Praia, the state was not present. And if that's the case, again, is there something that emerged which can be harnessed in a positive way for community healthcare, community systems? And then, Colleen, my question on Nicaragua would be, yeah, I mean, I think you basically talked about the way in which the government constructed a strategy and took agency. But maybe there's something which lower middle income countries in general can learn from that.
Thank you. My comment will be about what Kevin presented. Thank you very much. I mean, I'm really looking forward to your review. One of the problems is looking at. I mean, there's something what we call the streetlight effect in epidemiology. So one guy was in the evening lost his keys and looking for the keys under the streetlight. Sorry?
The famous Mullah Nasruddin. Your story.
Yeah. And then but he was looking for the keys under the light, and they asked, why don't you look at those bushes? And he said, there's no light there, so I can't look at there. So it does, when we come to these kind of studies or analysis, we always come, if there is data that we could present, and if there is no data, and then it becomes what is under the street light we can present and what is not. And that's a huge problem. It doesn't mean that wasn't the problem area, but this is one of the difficulties when we're looking at the existent evidence. Another problem, and that is that when the COVID impact, and of course on the other side of the equation, I always give this, this balanced picture of on the one hand side and on the other. If you look at the COVID side, there's huge data, and we tend to gravitate towards where data is. Also in the harms side, where we tend to gravitate where the data is. So we need to have keep it in mind. But also when we're looking at the harms side, if we put everything on the one pot, it might be becoming becoming to an average. So let me give you this example. The harms didn't influence everyone in the same way. Think of the mental health and the youth mental health, for instance. And I want to thank Reddy for being the voice of youth in this conference by bringing up that issue, because they were actually the 15 to 25-year-olds were the most affected by lockdowns, because I mean social interaction is the air they breathe. So it's not that important to my age group, but for them it's part of their development. They need to interact with their peers. That's the air they breathe, the water they drink. That's so vital to them. So if we think of that, let's say there's already a normal curve distribution before the pandemic. So there is a group, a large group, say, that is in the middle with the tip of the normal curve distribution, and they are averagely influenced. There is on the one hand side those who would never be influenced because of the environment they're in, but there is also somewhere here in the 15 to 25%, say, they were under vulnerable conditions already. They had a bad environment, they had pre-existing mental health issues, so they were, I call them the ones on the edge already. So what COVID did was to push these ones who were already on the edge towards probably the other sides. And but we shouldn't assume that. I mean, if we put them all in one pot, we might be losing the statistical significance of showing all the harms. But actually those who were most vulnerable, and also the statistical curve probably altogether moved to a shifted towards worse side. So so altogether there was in the mental health of the youth, there's probably a shift towards the negative side. But if we have a cutoff point here, those who fell from the cutoff point were more to that borderline groups.
Yeah.
And I think we need to keep that in mind, that the impact wasn't the same for everyone, and different groups may have influenced differently. And yeah, I look forward to your analysis. And unfortunately, those kind of impact studies come mostly from higher income countries, because they also have the baseline. So that the baseline is the biggest problem. And yeah, working with a lot of public health institutes, they are, in the beginning of the pandemic, no one thought of taking a baseline, by the way, because it was so abrupt about any policy they implemented. Also, like, you remember the mobile phone apps that were implemented, that the Bluetooth apps, that if you were in certain proximity with people, they would warn you, and they were the hype in the beginning. So, for instance, there's no data about their effectiveness, because they couldn't think of putting a baseline and seeing how it worked. Okay, thank you.
Hi, thank you. I just was really thinking on following what Isuda was saying about the whole matter around risk and future planning, because I mean, you know, setting aside the data, what struck me throughout this is the politicization of the public understanding of risk is such a massive issue. I mean, we are so bad, you know, as a species at determining risk, and there are so many kind of, you know, activities that we partake in plain sight. The evidence of that, I mean, the national lottery being one of them, utterly and completely absurd. But I'm just, in terms of future planning, I mean, I'd have thought this is probably one of the areas that needs a huge amount of thought, because how do we communicate to the public in a way that people can make their own decisions? I don't mean just within country, but across countries, and that would strike me as being one of the most important things to get, you know, to get really into. And I mean, reflecting on some of the discussions we've all had, and one of the sort of tragedies of the last few years is, in effect, a perversion of the precautionary principle. You know, the precautionary principle is fine as a way to proceed, if and only if you take into account the costs. But then you need to think very carefully about where you apply it. And the perversion in my mind is that the precautionary, we actually knew a lot about coronavirus to start with. I mean, in fact, with the one heuristic that basically gives you every information you need to know to design a public health policy is the age distribution. I mean, which obviously is a moniker for comorbidities. But the one thing that we knew nothing about was the effectiveness or the harms of lockdown. And you could imagine the harms. It didn't take much to figure that out. But whether they would be effective or not was taking a colossal policy risk. I mean, it was a massive experiment. So we flipped. But the idea that you could do that in public debate, in a way that the public went along with it, has to give us great cause for fear and concern. So for future policy, I would be really interested in your reflections on how we could actually approach that problem.
In Cape Verde, the state is absence. It's true. And in context of COVID, if not the informal welfare state in community-led for the women, the habitantes, we say the informal vendors, women informal vendors, the situation is worse. But talk from Cape Verde, I think the social positive impact from COVID is the need to organization to organize it and push back, because it's more active because the situation and absence the state in Cape Verde, in Praia in particular, but in Cape Verde in general.
When coronavirus, the first case was discovered in Mozambique, it was like this is the end of Mozambique, because the information which came from the global north, especially from Italy, Germany, is that many of people were dying, and those countries are rich. What is going to happen with us who are poor? So the decision was those measures, social distance, closing restaurants, school, and so forth. And health institutions were only dealing with coronavirus situations or people who had symptoms of coronavirus. And what happened that disease like malaria, vaccination for children were kind of neglected or suspended. But later on, because there were some people, medical doctors used to say, no, we are making a mistake because people are suffering and dying not because of coronavirus, but because of other disease like malaria. These children used to die also. So the president later on, after discovering that those measures were more political measures and not scientific measures, created a scientific and technical commission to deal with the coronavirus issues. And from that time onwards, that commission used to admonish or counsel the president or the government what we're supposed to do. So the government brought another decree, saying that we're not supposed to neglect other diseases. So it's better also to treat those people coming with other diseases because they come up or to the knowledge that people were dying not because of coronavirus, but because of other diseases. So after the commission was created, things changed. Instead of just dealing with coronavirus sick people, dealing with other diseases. The measures, as I said, were political measures and not medical measures. That is one of the reasons. Another reason is that people were saying stay at home or study online lessons, but there were no conditions created, no subside or no condition for those poor people. So it's not a matter of saying stay at home, but you have to create condition. And another problem was, as I said, corruption, because those restaurants, those places that were supposed to close, sometimes they didn't close as long as they have money to give those who are controlling, like policemen. And I think one of the things that could be done, instead of just reproducing measures that came from North Global or World Health Organization, it was supposed to create a scientific commission and to analyze if those measures are suitable for our situation. How can you say social distance in the public transport while we are not sufficient transport? How can you say stay at home while we don't have food? So it was like reproducing the measures coming from North Global and not dealing with our really situation.
Just comment quickly on this idea, because the traditional model here, if you go to the development studies, and we think about the influence of the World Bank and International Monetary Fund on a country like Mozambique, they would be dangling some sort of budgetary, need for restructuring or privatization, or else we don't give you this money and your currency collapses. So there's sort of an economic threat involved there. I don't. Maybe you can correct me, but I didn't see that here. Like, I think Mozambican politicians were free to go against the advice of America, etc. Maybe I'm wrong here. Maybe I'm wrong.
Coming up earlier, there's a serious problem with how you think the World Bank acts.
Right.
The World Bank is not something that calls you and says you do. Of course, there are contracts where they sign off conditionalities, but that's not the way it acts.
There's a soft. I'm creating a caricature, but there's soft pressure that runs along those lines. But anyhow.
Just think of Turkey. They didn't have to say anything. You cut down visas. Then you can't do business with the global north. Tourists stop coming. So you try to, cater your policies to their expectations so that the tourists come, business continues. They don't even have to say anything. You just, immediately turn towards how do I maintain my relationship with Germany because they're my biggest business partner.
Remember, almost every policy that the World Bank Bank, including now the shift to private insurance, etc., is always posited as the local government wanting it and World Bank reluctantly going that way and providing the technical assistance for that. It's always, they brought out a statement, WHO and World Bank, saying we are totally eclectic about the roadmap you choose to go. You can go by any route possible, but right there they were actually dictating their particular terms on that. So those who got universal healthcare were specifically people who went against the dominant thing. So it acts by many ways. They don't, for example, deal with the health ministry. They deal with the finance ministry. Very few people. I know this because I've seen the World Bank pressure, how it operates in India. On the table, they are saying one thing, but actually through the finance ministry, what are the terms of the loans they work, it's an entirely different thing on that. So World Bank does very much set the pace. Now you see this walking the talk, the latest primary healthcare. You would think for a minute they have become the greatest promoter of primary healthcare after Alma Ata. It's not so. If you actually done a critique of that for a different purpose on that, it's actually trying to show, because primary healthcare has been largely state provided, publicly funded and public provision. Purchasing has not really worked very well in most situations in LMIC, purchasing primary healthcare. So this is actually a book that shows how you can purchase, the different techniques you can purchase, the different best practices on which purchase can happen. But it's a different way in which the World Bank influences. So I think many of these were completely driven by this within that compact, but it just doesn't happen that way. I mean, it's a much longer discussion. Anyway, I think there's somebody, I think Colin should comment on the World Bank thing much more appropriately than
It's basically, it's interesting, no? Because the World Bank has a very good opinion of Nicaragua's development process, probably one of their best portfolios in the world, and also the IMF. But the Nicaraguan government, and when you talk about finance ministries and the other ministries, they work together. They don't negotiate together when they're doing sector projects. And that's what needs to happen in the sense of, you know, if health is a human right and the state wants to do it, then, you know, a design of a program that you start discussing with them, and you don't do it with budget support. Now, that's the other thing. After Ebola, for example, you know, there was, because my last job at the bank was advisor to the vice president of the Africa region, so I would review all the projects. And all the health projects post-Ebola were budget support. So you do 2 or 3 little easy things on policy, they give you $300 million, and then there's no accountability of how you spend it. So the question is for countries to do specific projects on well planned and start solving the problems of the basic health system, because or what they did in Liberia, for example, in education, they left it. You know, they spend all the budget support on different things, and all of a sudden, most of the education is in the hands of NGOs, which is also not acceptable. And so it's just a matter of a country taking control of the relationships with the World Bank. And also the IMF. Nicaragua has not been a, quote, client of the IMF since like 2013, because they said, no thanks, you know. But then the IMF says, well, can we come every 6 months? Yeah, come every 6 months and evaluate the economy if you want. That's the way they do it. But it's the turning around these negotiation processes. The government has to be in control and know what you can do, and not just accept the easy money.
The nature of how these global institutions influence and control the thing is no longer the simple, it's not a dictation. It's also very many things, the leadership, their own aspiration, the policy community, how they shape the policy community, who gets the trips, who gets the World Bank position, they take care of their own. I mean, in some sense, it's very well, I think so.
The World Bank has been funding autocratization in Turkey for the last decade. I'll just say that. They've been autocratization. They've been funding our path to dictatorship. I don't know why they're so eager to do that, but you know, they've been giving money to the government to be spent on very undemocratic things that support autocratizations.
And right now, as we talk across the World Bank is rolling out loan for the post-COVID recovery on the health sector,
Right.
where they are in a particular architecture shaping the health sector.
Yes.
One part of the investment is going into surveillance, another part is into a certain type of health systems preparedness. In both of these, there is a certain storyline, a certain narrative that is being promoted right across. And all the countries are getting indebted
Yes, right.
for a policy that
Yeah.
they could have done much better without this.
Yeah.
And the whole pandemic treaty negotiation, where that is happening and where we should feed in as from this discussion. There's a serious take. I hope it will come tomorrow or sometime in this discussion on that. Because there is a serious take on how I think that they are very much setting the pace and they are leading to a privatization of health sector
Yeah.
in the way they are doing it, and they have made full use of this opportunity without ever speaking up like that. How do they?
But then there should be more speaking up of the different countries, really, because the countries have to be in charge, not the World Bank. And again, specific projects for specific things, and not budget support that the finance minister can just spend on anything.
World Bank is a little government in Cape Verde. Like that. After, in another government, is the United Nations. We have the election in 2060, and the new government say, okay, we don't care about the United Nations, now is World Bank. They put much money in Cape Verde, for what? I don't know. Because the people in the community don't see anything.
I was just going to steer the conversation to Alex's question here on. So he was asking about risk, right, and sort of what we can do to try to address, I guess, the
perversion of the precautionary principle.
Right.
I'd like you to reflect on that particular last phrase. It's an important one because it goes back to what I was saying about the relationship between risk and uncertainty.
Yeah.
You use the precautionary purpose principle in a situation of uncertainty where it is unquantified risk to actually take the worst case scenario as your the scenario to be acted upon. Something like that.
Yeah, I mean, there's so much to unpack with that question, and I have notes scrawled on all sorts of pieces of paper. But on the one hand, I would say that it's a value-based battle almost, right? And it seems like if you simplify it, at the beginning of the pandemic, there were sort of two roads you could take. One was to say the virus is a big problem, and that came with all sorts of other value-based judgments, like, for example, it's a human right to be protected by from the virus, right? The government needs to protect me from COVID, and that's like its responsibility to me as a citizen, right? That's a very kind of like specific conceptualization of the government's role. And then the other one was, I'm a citizen, you can't take away my civil liberties, etc. So there were a couple of these different value-based judgments that guided things. I also think there's a lot to say about the cultural antecedents here that were already laid. I actually think that we were, as a culture, and I'm speaking here from Northwestern perspective, but I would think, and I don't know how this translates to other countries, but we were almost primed for like this existential threat that was supposed to annihilate us from all of the sort of dystopian movies that we've been watching, science fiction movies, and the idea that, we all have to do something completely new had been already set, and it was almost exciting in some degree, so I think that played a role in it. But what can we do? I think it's really quite critical for us in this room to keep talking about this subject. And we might feel like, oh my goodness, I've been talking about this forever. I already know this. But a lot of people are not talking about it and they don't know about it. And that the machinery of the state response has been laid. The next crisis, it's going to be the same machinery that's going to come into place. From lockdowns to vaccine passports or some sort of form of digital, passes to get into places, et cetera, et cetera. So I think that it's very fundamental for us to articulate the risks associated with the response to a virus. So there's the virus, and then there's the efforts to control the virus, and that can be, like I'd said earlier, almost more deadly or more disruptive than the virus itself. So I just encourage all of us. We might feel like, I've said this 30 times. And I guess the question, though, is how do we reach out to other people to make them aware of these harms, right? What are the best forums? Who are the audiences that we want to talk to? So I'll leave that question for everyone else to answer.
Can I answer the risk question? So it's about the risk baseline. I mean, if you look at the global north, especially if you look at rich people, the amount of risk they face in their daily lives is so small that every small thing could be considered a risk. And that's what everyone has been talking about. If your life is so safe, then a respiratory virus is a real threat. Statistically, it's a real threat. It increases your chance of dying many, many, many times. But it's a blip on the risk, of someone, for example, living in a different country. So actually, the perception that this is a real threat and risk in certain countries, in certain populations, that was also not unreal. And unfortunately, those people rule the world, the people that live in extremely safe environments, and every tiny thing is a significant increase of risk in their lives, rule the world. But also, I'm a political scientist, and in political science, we always make this distinction, public interest versus special interests. Now, we were kind of involved in what was going on in Turkey, and every decision that you make involves special interests, but not the public interest. Nobody speaks for the kids. Who will speak for the kids? Like, nobody does. And actually, if you look at political science literature, certain groups are very underrepresented in policymaking. They have almost no impact on policymaking. Rich people have the shocking, I know, highest impact on policymaking across all issues. Now, if you look at COVID, it's not just rich people, but also you want to close the restaurants. Well, how much power do restaurant owners yield in your economy? How much power do hotels have in your economy? In Turkey, hotel owners were a big deal, and they literally went to the ministries and they talked to the minister, they had access to them, and they didn't let the hotels to get closed. It was that simple, right? It was an economic decision, and they had power. They had influence over politicians. They were also, cronies of these politicians. Schools, teachers loved school closures. I mean, in public, they were like, oh, children. In private, everyone we talked, well, I'm at home. It's okay. There were some people that were overworking, but the majority of them actually did not even have to do the online thing fully because there was access, this, that problem, whatever. But a lot of people weren't that unhappy with sitting at home. A lot of white-collar workers weren't that unhappy, at least for a while. So and when they were not happy anymore, that's when, the states started, So whose interests are we talking about? Unfortunately, public health decisions are not made according to principled discussions, evaluations. Who's in the room? We are not in that room. Children are not in that room, and the poor are not in that room. And if we're going to do anything, it should be to shout, from the rooftops. Like, if you're going to make any decision, you should always think about the poorest, the most disadvantaged. How are they going to be affected? Because we always know how the privileged are going to be affected. They know it. And if we're not going to bring that into that discussion, somehow force that into this discussion, we'll keep making these so-called mistakes. They're not mistakes. They were intentional. And that's why, think of it like this. Every shock to the system is an opportunity for people with power to pass the policies they want, both globally and nationally. And they use this as everything is an opportunity to neoliberal, whatever, privatize this, privatize that. How do you come out of a pandemic with policies that privatize healthcare? That's insane. Because the first month we saw, private healthcare doesn't really function. And then we came out and we're being told, privatize your healthcare. It's all an opportunity. So, we need to be careful about whose interests we're talking about. We need to bring that discussion, because once you don't, it's, who people take their cues from? The political leaders that they trust. It's all polarized. It's like Democrats versus Republicans, this versus that. But everybody's actually mimicking something that they don't really understand. And in the end, no matter what happens, the rich win.